Okay, when we talk about drugs for perfusion, the first classification that we're going to talk about is the antihypertensives. Okay, so with the antihypertensives, we have a number of different classifications that we can use. Okay, and so when we look at antihypertensives here, we can see we have calcium channel blockers. That's one classification. And here we have the beta-adrenergic blockers. That's the second classification. Okay, so first of all, let's talk about the alpha-adrenergic blockers. So these are going to block the alpha-1 receptors. Okay, what did alpha-1 do to the blood pressure when you stimulate alpha-1? It increased the blood pressure. So these drugs are going to block alpha-1, so the blood pressure is going to go down. Actually, they're going to cause vasodilation. And the result of vasodilation, think about that. They're going to dilate the blood vessels, and when you dilate the blood vessels, the pressure inside of them goes down. So the blood pressure goes down. Okay? Now, they happen to do something else. They happen to decrease the bad cholesterol and increase the good cholesterol. We'll talk about cholesterol today too. The very low density lipoproteins and the low density lipoproteins, that's the bad cholesterol. And the high density lipoproteins is the good cholesterol. Now, doxazosin mesylate is one of the alpha-adrenergic blockers. So is prazosin, terazosin. The alpha-adrenergic blockers end in azosin, so you can easily recognize those. It would be nice if all classifications of drugs did that, and they put all the drugs in that category to end in a common, suffix, but that's not the case. But these you can easily recognize because they're all azosin. All right, nursing considerations. What do you need to know? Well, first of all, they'll drop the blood pressure. In the very beginning, when you put the patient on a blood pressure medication, the blood pressure will drop significantly first couple of days. Patient may stand up from lying down and they say, oh, I feel like I'm going to faint. Okay? Dizziness, hypotension, syncope is fainting, may give them a headache, that type of thing. Now, a couple of years ago, someone did a study about blood pressure medication to try to find out when you had these medications that were only given once a day, when was the best time to give them. And what they found was that most MIs and strokes happen first thing in the morning. And so the best time to give an antihypertensive was at bedtime. And that way you ended up not having a high blood pressure first thing in the morning, and you prevented many MIs and CVAs. And so they'll tell you to, if you have a high blood pressure medication by itself, take it in the evening at bedtime. Now, when the blood pressure drops, okay, sudden drop in blood pressure, the body responds with a compensatory mechanism that we call reflex tachycardia. The body says, well, you're going to drop my pressure, I'm just going to increase my heart rate. So sometimes you see that. These drugs also tend to make you retain sodium and water, and so you could end up putting the patient on a diuretic at the same time. You do decrease myocardial contractility, so the heart's not going to beat as strong, so you have to be concerned that you're not throwing the patient into heart failure. And so that would be something else that you would monitor for. Now, nasal vasodilation can be a side effect. Patients who take these drugs can say, oh, I feel like I'm so stuffy, okay? And that would be because of the nasal vasodilation. They also can cause GI disturbances, and so they may have upset stomach. Tell them to take the drugs with food, and that may help with that. Beta-adrenergic blockers. These sound familiar? Yeah. They're sympatholytic. If they block beta-1, you end up with vasodilation. That results in lower blood pressure. They also reduce the release of renin from the kidneys. Okay. Some can block the beta-2 receptors. Those are considered non-therapeutic. They decrease the heart rate, the cardiac contractility, and the excitability of the heart. So they also make the heart beat not as strong and decrease the heart rate. Now, you can have selective beta blockers that only block beta-1. That would be like atenolol or metoprolol. Okay, those only block beta-1. Or you can have your non-selective beta blockers like nadolol and propranolol. Now, one thing you'll notice about beta blockers is most of the generic names tend to end in OL. Okay, so you can easily recognize beta blockers. Some of them they may have an occasional one that may end in ILOL or something like that, but most of them end in OLOL. All right, so again, here we have propranolol, we have metoprolol, we have carvedilol. That one is an ILOL. They decrease the heart rate, they decrease the force of contraction, and they decrease that rate of atrioventricular conduction. In other words, they slow down the stimulus to the heart to beat as fast. That's why they're good drugs for atrial fibrillation, when the heart's beating the atria very quickly. Side effects. Well, think about this. You are blocking part of that sympathetic response. So you're going to have bradycardia. The person's going to feel very tired. Remember, the blood sugar is going to go down. They can have GI disturbances with these drugs, so they can take them with food. That would help. Congestive heart failure. The heart's not going to beat as strong, and when the heart doesn't beat as strong, the person can have some form of heart failure, but you don't want it to get so bad that they end up with congestive heart failure, because congestive heart failure is when they start retaining fluid around their lungs, their heart, peripheral areas, all of those areas where you don't want fluid retention. They do decrease the blood pressure, and many patients who take these say at least the first 6 months or so, they do experience some type of depression. They say it gets better with time. A friend of mine who was put on these for atrial fibrillation, she said the lethargy was so bad, the fatigue in the very beginning when she first started taking them. She would go home from work every day, she'd lie on the sofa, and some days she'd lie there until she got up and go back to work the next morning. And she said it actually took her about a year to get her energy level back up. So I guess your body eventually compensates for it. So for your nursing considerations, again, you're going to monitor for hypotension, headache, dizziness, syncope, bradycardia, fatigue. Remember, if you're taking one that's non-selective and you're blocking beta-2, and the patient has any problem with a chronic lung condition like asthma or COPD, emphysema, you may have problems with wheezing, not being able to catch their breath, things like that. We talked about heart failure, and use cautiously with patients with diabetes. What do you think it's going to do to the blood sugar? Yeah, decrease. And asthma because of the bronchoconstriction. Now, you can have a drug that's a combination sympatholytic on alpha-1 and beta-1. Okay, labetalol, carvedilol, carvedilol, those are combination alpha-1 and beta-1. So again, you're worried about the orthostatic hypotension and the fatigue. Now, we do have a classification of drugs that are antihypertensives called calcium channel blockers. They block the influx of calcium ions into the myocardium and the smooth muscle cells. The result of that, blocking the calcium into the cardiac muscles, is vasodilation. Blood pressure goes down. They also decrease myocardial contractility, so the heart does not beat as strong. And this is significant because calcium, they have found a study a couple of years ago that calcium can be partially responsible for MIs. What the study actually revealed was that those patients who took calcium supplements had an increased incidence of of MIs. That's what they found in that study. So now you kind of have a little controversy about supplementing your calcium. You know, cardiologists are going to say, don't supplement your calcium. And then you're going to have, with females, your OBGYN doctors that are going to say, supplement your calcium because you're prone to osteoporosis after menopause. Okay? So, I don't know. We have a little bit of controversy there going on between those two groups. Now, this is one of the classifications of medications that they found that patients who have an African American ethnicity seem to respond better to calcium channel blockers than they do to the beta-adrenergic drugs. So if you have a patient who is African American and they go to the doctor with their blood pressure high, one of the first drugs they'll probably put them on is a calcium channel blocker. For whatever reason, they just seem to work better with them than the beta-adrenergic blockers. I had a student several years ago. She was probably in her late 30s or so. She was African American. And she told me when we talked about these drugs that she took a calcium channel blocker. She had high blood pressure. And I think by the time she was like in her third semester or so, she came back to tell me one day that her blood pressure was very high, that she just took it in the lab and it was something like 220 over 140. And she said, what should I do? And I said, well, first of all, you need to call your doctor immediately and tell them what your blood pressure is because, you know, blood pressure that high, that's stroke level. You know, as if being in nursing school is stressful, huh? So as she went on, her blood pressure probably gradually went up. She did go to the doctor and they did put her on another drug. She came back to tell me later on they added a second calcium channel blocker. Okay? So she said, well, why did they do that and not give me one of the other classifications of antihypertensives? Well, the reason is when we look at calcium channel blockers, you're going to see they don't play well with other drugs. There are a lot of drug interactions with them. So chances are if the patient's blood pressure is being controlled by a calcium channel blocker, if they have to increase it, they'll either increase the dose. If they're at the maximum dose, then they'll probably go ahead and just add another calcium channel blocker to the mix. Okay. Calcium channel blockers are easy to recognize because most of them end in pene. Amlodipine, nifedipine, okay. Your nursing considerations, again, after you give it, you want to be concerned about possible hypotension. You want to make sure the blood pressure is not going too low. Headache, dizziness, syncope, that could be symptoms of that. Bradycardia. Now, avoid grapefruit and grapefruit juices with calcium channel blockers. You combine those and you could end up with toxicity of the drugs. Okay. You do decrease myocardial contractility, so be alert for those signs of heart failure. When the heart's not beating as strong and the patient's going into heart failure, they'll tell you things like, I'm so tired, I can't walk all the way to the bathroom, I used to be able to do that. You know, they'll tell you the things they can no longer do. That may be a sign of heart failure. Fatigue, things such as that. All right. The drugs that we just talked about, well, let me just say this. The beta blockers, those sympatholytic drugs, are not as popular any longer to treat high blood pressure. And one of the reasons for that is probably the side effects. You know, you're blocking that whole sympathetic response. There are preferred drugs now to treat hypertension. And the Renin-Angiotensin system drugs are some of the preferred drugs. So let's go ahead and look at this little video about how those drugs work. This is a good video.
What if there was a nursing college that met all of your requirements? One without prerequisites or wait.
Hi, in this video, I'm going to look at the Renin-Angiotensin aldosterone system. also known as the RAAS. So this all starts with the liver. And the liver produces an pre-enzyme called angiotensinogen. And this gets converted into angiotensin 1. And this occurs through the action of renin, which is an enzyme released from the kidney. And the kidney releases this due to low fluid volume moving through the nephrons. Now, angiotensin 1 gets converted to angiotensin 2. And this happens by an enzyme called angiotensin converting enzyme. Now, these are floating around in the blood, these angiotensins, so it's when they pass through the lungs that they meet ACE, which lives in the lung. And that's when angiotensin 1 gets converted to angiotensin 2. Now, angiotensin 2 acts on the adrenal gland, and it causes the adrenal gland to release aldosterone. And that's a steroid hormone, which then acts on the collecting ducts of the nephron. This is within the kidney, and causes the nephron to retain water. So I'll put here H2O retention. Then if the body retains water, the blood pressure goes up, and in some people this can be a bit of a problem. Now I should also put in one other thing that's very important about angiotensin 2. Angiotensin 2 seems to be a factor in the inappropriate remodeling of the heart after a heart attack, and this can cause significant morbidity and mortality in heart attack patients. So let's have a look at some drugs which we can use to affect this pathway. The most common drugs are the ACE inhibitors. So these are the angiotensin converting enzyme inhibitors. So obviously these inhibit ACE. The next group of drugs are called statins, or angiotensin 2 receptor blockers, also known as ARBs, and they stop the effects of angiotensin 2. And then a third set of drugs block the action of aldosterone. And the most important of these is spironolactone. It's also important to note that by blocking the action of angiotensin 2, the ACE inhibitors and the statins can prevent the remodeling of the heart after a heart attack. So these drugs lead to a lower blood pressure and a better outcome after a heart attack. And that's an overview of the renin-angiotensin aldosterone. For more free tutorials and the PDF of this tutorial, visit www.handwrittentutorials.
Okay, did that make sense to you? Yeah, so that kind of shows you exactly how those drugs work. Okay. So, ACE inhibitors, first of all. They block the conversion of angiotensin 1 to angiotensin 2. Now, why is this important? It's important because angiotensin 2 is one of the most potent vasoconstrictors in the body. So if you're blocking a vasoconstrictor, you end up with vasodilation. You also have decreased aldosterone release, and therefore you don't reabsorb as much sodium and water from the kidneys. And so you have less circulating volume, which again will lower the blood pressure too. Now you can recognize ACE inhibitors because ACE inhibitors end in pril. Okay, so here you have benazepril, ramipril. Okay, so your pril drugs are your ACE inhibitors. So here you see we have captopril, lisinopril, enalapril, quinapril. We've got quite a few of those in that category of ACE inhibitors. Now, the second group of renin-angiotensin drugs are the angiotensin II receptor blockers, the ARBs you hear them called sometimes. They block the binding of angiotensin II to those receptors in the smooth muscle and the adrenal glands. And so you end up blocking that vasoconstricting effect of angiotensin II. So you don't have the blood pressure going up, you have the blood pressure going down. It also, again, decreases the release of aldosterone, so you have less sodium in water. Now, these drugs, the patient will not lose potassium. So you could end up with a problem with a high potassium in the blood, hyperkalemia, we call that, okay? So make sure you tell your patient don't supplement your potassium. Now, you can recognize the ARB drugs because they end in sartan. Irbesartan, isosartan, valsartan. Have y'all heard of any of these in the news lately? Valsartan, what are they saying about valsartan? There was a recall on it because valsartan went off of patent protection a couple of years ago. So now we have different manufacturers making generic versions of valsartan. Well, several of the manufacturers were using an ingredient to make valsartan that is a known cancer-causing agent. And so when they detected that, they went ahead and pulled the drug off the market from those providers. So what they're doing is they're switching the patients to another sartan instead of valsartan if they can't get it, because many of the pharmacies are having trouble getting them. And so that's the latest that's been about those drugs. Now, nursing considerations. Again, they're going to drop the blood pressure. So headache, dizziness, syncope could be side effects. Angioedema. What's angioedema? Yeah, it's swelling in the facial area. So the patient may look like they have puffy eyelids. They may look like their face is a little bit rounder because they're retaining fluid in that area. They also could have a tickling sensation in their throat. They could develop a cough, and they don't really have any reason to have a cough. Patients who've had that will tell me it almost is like they feel like they're choking, and there's nothing there, okay? The only thing you can do for patients who experience that symptom is to take them off the drug, switch them to a different drug. And they say that if they have that side effect with one of the ACE inhibitors, they're probably going to have them with all of them, okay? So they'll switch them to a different classification of drug. For some reason, it seems to not happen as often with the ARBs as it does the ACE inhibitors. Now, again, watch the potassium level. It could go up, no supplements. And these drugs work in the kidneys by blocking renin. And so you're going to end up in a situation where the patient has to have good kidney function. So they're going to monitor probably the BUN and creatinine to make sure their kidneys are working well. Now, central acting adrenergic blockers. These are another type of antihypertensives. They suppress the sympathetic activity in the medulla of the brain. So these work differently. These work in the medulla of the brain, not the kidneys. Y'all remember alpha-2? What does alpha-2 do when you stimulate it? It decreases blood pressure. So these are alpha-2 agonists. Okay? They stimulate alpha-2, and the result of that is the blood pressure goes down. Vasodilation occurs. That lowers the blood pressure. Clonidine is a drug in this category. Now, I'm going to tell you, you don't see central acting adrenergic blockers work prescribed as often as you do the other drugs. And the reason is the side effects. The side effects of these are pretty tough sometimes. Drowsiness, mental depression, bradycardia, impotence, urinary retention, edema, dry mouth. So they have some pretty tough side effects. I know years ago when I would take patients to clinical at Charity Hospital, you know how when you do your nursing health history, you have to ask a general question about sexuality. And we'd have patients who would say, usually older men would say, oh, yeah, well, that doesn't work anymore. And it's like, well, what do you mean it doesn't work anymore? Oh, well, about 10 years now, it just stopped working. Well, it just stopped working? Well, what happened 10 years ago that it stopped working? Oh, I don't know, my blood pressure went up. And when my blood pressure went up, it just stopped working. Well, when you trace it back, you see they're on a central acting adrenergic blocker. It could be a side effect, but maybe no one picked it up. Maybe no one asked those questions. And so as a nurse, if you discover that, what you would probably do is inform the healthcare provider, because if it's that important to the patient, they could probably just switch them to another drug. But honestly, what I see most often is the only patients now on these drugs are pretty much patients that some of the other drugs did not control their blood pressure well enough. Because of the side effects, they tend not to use the central acting adrenergic blockers as often. In fact, the preferred drugs for hypertension right now are the ACE inhibitors in the ARBs, the Renin-Angiotensin system drugs, because they have less side effects. Okay, so go ahead and get out your parish handout, the parish. We're going to look at a family, and these families, this family over the semesters, we're going to use the same family in Form 1, 2, and 3. They're going to develop some health problems, and they're going to be prescribed some of these medications. Okay? For example, the first one we're going to look at is Joe. Joe's a 78-year-old male, and together he and Angelina own and operate an Italian restaurant that has been in Angelina's family for generations. He has a history of hypertension, having been diagnosed with it over 20 years ago. So when a family is, okay, so he's going to be prescribed a diuretic first. We'll talk about diuretics in a little bit. So let's look, first of all, towards the end of the page. You have that chart of antihypertensives. Okay? Now, this is like just a synopsis of what we talked about today with these different classifications. You see the first one there we have is alpha adrenergic blockers. So you see some of the nursing considerations there. You have how they work, and then some of the drugs. Remember, those end in azosin. And if you turn the page, then you have the rest of those classifications. So just, again, a review of how they work, what the nursing considerations are, and the names of these drugs. And they did a great job naming these drugs, in that we can probably pick out most of these by the suffix, what they end in. Unfortunately, all drug classifications are not like that, but the antihypertensives do seem to be. Okay, so for these classifications, you will have on your next test, and all the tests from here on out, you will have questions about drugs that will be either based on the classification or it'll be based on the name of the drug. Okay? If we look up a specific drug in the parish here, okay, if we go over a specific drug, you better believe there's probably a 99.9% chance you'll have a test question on that drug. Okay? The others might come from this chart. I may tell you the patient is taking a calcium channel blocker. What is it important to instruct the patient about? Okay? It could be any of these nursing considerations here. Monitor your blood pressure, your heart rate. Avoid grapefruit. Okay? You might assess whether or not the patient feels very tired because of that decreased myocardial contractility. Anything that would go along with those nursing interventions. What possible side effects? Well, I don't have that listed here, so the specific drugs we've learned side effects. All right? So let's look at these. First of all, the first one there is valsartan. So Joe's physician prescribed valsartan, 320 milligrams PO daily. Okay, we know it's a renin-angiotensin antagonist. It's contraindicated. Contraindicated means when you should not take it. Okay? Patient already has heart failure, compromised renal function, because remember, it's an ARB drug, Renin-Angiotensin drug. It works in the kidneys. Have to have good kidney function. Dehydration. If they had angioedema with ACE inhibitors, they may also have it with ARBs. And so that may be a contraindication. And then pregnancy. Okay, before you give this medication, before you give any antihypertensive, you're going to check the blood pressure. Okay? When you go to give it in clinical, your teacher's going to talk to you about your meds first. They're going to say, what's the patient's blood pressure? I don't know is not the right answer. They're going to tell you, go take the blood pressure and come back. All right? Imagine if you had a patient with a blood pressure of 70/40 and you gave them an antihypertensive because you didn't bother to check the pressure first. That patient could be in real trouble. Okay? So we're going to check the blood pressure first. And with valsartan, you get a maximum effectiveness in about 2 to 4 weeks. And so it'll probably gradually decrease the blood pressure. Now, I'm not going to ask you on the test doses unless I tell you you need to know the doses for this drug. So I have them listed here, but that's not going to be the test question. So interactions, none. Great. It plays well with other drugs. Okay? Don't have to worry that much about what else the patient's taking. No common side effects. Great. You can see why it's one of the preferred antihypertensives. So nursing interventions, give on an empty stomach. Okay? And remember, we give most antihypertensives in the evening. So this one would probably be a good one for the patient to take at bedtime, right before they go to bed. Monitor liver function, BU and creatinine. So this one's hard on the liver and the kidneys. Potassium levels. What's the potassium level probably going to do? It might go up, because remember, you don't lose potassium with these drugs. So no potassium supplements, and assess for dizziness with position changes. Okay, so after taking the valsartan for 2 years, Joe's high blood pressure on his last visit to his physician is 162/102. So the physician prescribed atenolol in addition to valsartan. Valsartan, the maximum is 320 milligrams a day. So Joe was already taking the maximum of valsartan. So instead of increasing the valsartan, which he could become toxic if you give over the recommended, they just added another antihypertensive. So why do you think they would give 2 different ones? Because they work in different ways, right, to lower the blood pressure. So we're going to attack it from a different way. So they gave him atenolol. Atenolol, the brand name is Tenormin. You don't need to know the brand names. All your questions are going to be by the generic names. I put the brand names there because in clinical, you may have some places that refer to drugs by the brand names. So at least you're familiar with it. Okay, it is, atenolol is a beta-adrenergic antagonist. Do y'all remember, is it selective or non-selective? It's selective. It only blocks beta-1, so we're not going to have to worry about bronchoconstriction with this one. It's contraindicated with bradycardia, congestive heart failure, and pregnancy. Okay, so blocks beta-1. Before you give it, check the blood pressure and the heart rate. You might even tell the patient who takes an antihypertensive to check their own blood pressure at home. Okay? That's something that is a whole lot easier now for patients to do than it used to be. I have a neighbor that over the Christmas holidays, she asked me to help her select a blood pressure cuff to measure her blood pressure. And she's an elderly lady, and she said she'd been having trouble at home lately with fainting. And she'd had to go to the emergency room several times because she hit her head one time and that type of thing. And she said, but I take antihypertensives, and if I don't take them, my blood pressure's sky high, but yet sometimes my pressure must drop because I faint. I said, well, do you feel weak before you faint? Yeah, I'm usually weak for a couple of hours before, it seems like. So they recommended to her that she take her blood pressure at home. Not a bad idea. we don't have to have as accurate a pressure at home that you do in a hospital. And so there are other mechanisms that they can use. And what I looked for with her was the simplest one possible. So I actually found one at Walmart that slips on your wrist. Have y'all seen those? And it gives you a digital readout. Well, it must use the radial artery right there to get the reading, because it shows you to put it over the radial artery. So I tested it on her, got the blood pressure, and then I used my regular cuff and checked the blood pressure to make sure it was accurate. And it was accurate, I think, within about like 2 or 4 millimeters of mercury. So that's pretty accurate for a digital cuff like that. So it's not a bad idea for them to do that at home. Okay, it interacts with. Now, interactions can mean that it's not compatible. It could mean it could make the medication toxic. It could mean it could make the medication ineffective. In other words, you've got some type of interaction going on there. Anticholinergics increase the absorption of the medication. So you probably wouldn't give the patient atenolol and an anticholinergic. Insulin. If the patient's taking insulin, they may have a problem with hypoglycemia, the blood sugar going too low. Remember, this is a beta blocker. It's going to lower the blood sugar. And it also interacts with NSAIDs. Now, NSAIDs, that's an abbreviation for non-steroidal anti-inflammatory drugs. That's your medications for pain, your non-prescription pain medications. Not Tylenol, not acetaminophen, but aspirin, ibuprofen, naproxen, any of those are considered NSAIDs, so you don't combine that with atenolol. Side effects. Okay, when I look these drugs up in the drug guide, there might be 50 side effects for this drug. The nurse is not going to know all of those, but you should know the most common ones are the life-threatening ones. Okay, so the most common ones with atenolol are bradycardia, pulse goes too slow, hypotension, blood pressure goes down too low, congestive heart failure. Remember that you're decreasing the force of myocardial contractility, so the heart's not beating as strong, and fatigue. Beta blockers cause a lot of fatigue. So for your nursing interventions, you're going to check the blood pressure and the heart rate, monitor the blood glucose with diabetics. Orthostatic hypotension with antihypertensives usually happens in the first few weeks. And tell your patient, don't abruptly stop taking this drug because you could have that rebound hypertension. And limit the alcohol intake. Okay? All right, let's see. What are some other drugs that Joe's doctor could have given him? Well, it could have been benazepril. Benazepril is what type of drug? It's a pril, so it's an ACE inhibitor. Okay? Remember, that's going to work in the Renin-Angiotensin system. It's going to block the conversion of angiotensin 1 to angiotensin 2. Angiotensin 2 is a powerful vasoconstrictor. It's going to cause vasodilation. That's going to lower the blood pressure. Before you give it, you check the blood pressure. Now, it interacts with potassium-sparing diuretics. Okay? Remember, you don't lose potassium with the Renin-Angiotensin drugs. And so you end up retaining potassium. Also can increase the toxicity of a drug called lithium that we use for mood disorders. Most common side effect with benazepril is headache. So for your nursing interventions, assess the blood pressure, monitor the potassium level, no potassium supplements or salt substitute. Salt substitute is potassium chloride instead of sodium chloride. And report any swelling of the face, eyes, tongue, or difficulty breathing. That is could be angioedema. All right, another antihypertensive is clonidine. That's the central acting adrenergic blocker. Remember, this one works in the medulla of the brain. And contraindicated if the patient has any problem with blood coagulation. We call that coagulopathy. Now, before you give it, check the blood pressure, and you're going to closely monitor the blood pressure at the beginning with this drug. The person could retain fluid in the first 3 to 4 days and gain a few pounds the first 3 to 4 days. After that, it does get better. There are many different ways to give this one, not only orally, but you could have patches, you could have extended release with this drug. So there are a number of different ways to give it. It interacts with alcohol, central nervous system depressants. Because it works in the brain, it's probably not going to like being combined with other drugs that work in the brain. Central nervous system depressants are things like antihistamines, your opiates, your narcotics. A lot of your medications for mental illnesses are central nervous system depressants. Anti-anxiety drugs are central nervous system depressants. Tricyclic antidepressants and MAO inhibitors, those are both antidepressants used for depression. Opiates, we said, don't combine well with them. And if you combine them with a calcium channel blocker or a beta blocker, then you could have bradycardia. So monitor the blood pressure, the I&O, because you retain that sodium in that water. Weigh the patient daily. Change position slowly because of that orthostatic hypotension. Don't take over-the-counter meds, alcohol, or central nervous system depressants unless you check with your healthcare provider first. You know, they're going to look it up in a PDR, and they're going to have a whole list of things that interact with this medication. They'll be able to tell the patient, yes, you can take it with that, or no, you can't. And avoid being overheated or dehydrated. Now, the next drug is amlodipine. What type of drug is amlodipine? Calcium channel blocker, because it ends in pine. Okay, the trade name for this, I have an error on this paper. It's Norvasc, N-O-R-V-A-S-C. So change that for me. It's not Tenormin. That was atenolol. This one, amlodipine, is Norvasc, N-O-R-V-A-S-C. I need to correct that. Contraindicated with pregnancy and if the patient already has coronary artery disease. Okay, we talked about how it blocks calcium from going into that myocardial muscle. The result is vasodilation. That's what lowers the blood pressure. So before you give it, check the blood pressure and the heart rate. It interacts with many other antihypertensives. So calcium channel blockers do not combine well with other antihypertensives. That's why many times they either increase the dose or add an additional calcium channel blocker. Grapefruit. Can't have grapefruit or grapefruit juice with these. Also, there are certain herbs it doesn't combine with. Here you have ephedra, mahuang, melatonin, and St. John's wort. You know, the general public thinks that herbs are natural substances, so they're perfectly fine. The problem is when you start combining herbs with prescription drugs, you have a lot of interactions. St. John's wort actually interacts with 60% of all prescription drugs. Yeah, I bet you the general public does not know that. All right, side effects, peripheral or facial edema and headache. Those are the most common with amlodipine. So monitor the blood pressure and heart rate, check for peripheral or facial edema, orthostatic hypotension, so change that position slowly, report any shortness of breath, palpitations, irregular heartbeat, nausea, or constipation to the healthcare provider. And that is the one thing that many times we don't do when we teach patients about medications, is tell them when to report a side effect, okay, what to do about it. And so what happens? They get home, they have a side effect from the medicine. What do? They just stop taking it. Right. Well, if it's something like an antihypertensive, that could be dangerous. You know, they could end up with a stroke or an MI or something like that. And so tell them what to report to the healthcare provider. All right. Any questions about the antihypertensives? Okay, next we're going to talk about the medications for cholesterol, but let's go ahead and take a 10-minute break and then we'll continue with these. Okay, let's continue by talking about drugs for high cholesterol. The medical diagnosis for high cholesterol is called hyperlipidemia. Hyper is high, lipids is fats, emia is in the blood. So high level of fats in the blood. Now lipids consist of cholesterol, triglycerides, and phospholipids. Now 2/3 of all the cholesterol in your body is endogenous, meaning it's made in the body. Okay? Your liver makes cholesterol. 1/3 comes from the diet. Okay? Now, do you know someone who seems to eat pretty healthy but has a real high cholesterol? Yeah. Cholesterol can be, some people are just cholesterol makers, okay? No matter how they alter their diet, they still have high cholesterol. It tends to run in families. It's hereditary, okay? I have a friend that every time I'm with her, it's like, she has a high cholesterol, like 300 something before she started taking medicine. And her diet is like, I mean, she's always eating salads and green stuff, and she'll think that, you know, steamed broccoli and cauliflower for lunch by itself is delicious. And it's like, are you kidding? She's a cholesterol maker. She has to take the medicine. Otherwise, her cholesterol is real high. She has a high incidence of cardiovascular disease in her family. Her dad died at 65 of an MI. And so people like that are good candidates for cholesterol medication. No matter how they alter their diet, it doesn't affect their cholesterol level. Now, it's important that we have lipids in our bloodstream because they help absorb and transport the fatty acids. Where do we get cholesterol from? Well, we think about in the diet that we get it from animal fats, shellfish like shrimp, and some of the others will have cholesterol, oils, especially those saturated oils, egg yolks. Those are typically what we think about of foods being high in cholesterol. But our body can take triglycerides in the liver and make cholesterol. And triglycerides we get from animal fats, oils, and simple sugars. That's why you can have someone who they may tell you, I don't hardly ever eat meat, okay, and they have a high cholesterol. Well, it may be that they have a high carbohydrate diet, and the liver is going to take those triglycerides, which you get from the carbohydrates, and make cholesterol out of it. So they think now that sugar in the diet, carbohydrates, has as much to do with cholesterol as animal fat sometimes. I had a doctor tell me a couple of, about a month or so ago, that what she's noticing is that these people who are on this keto diet, y'all heard the keto diet, where you pretty much eat a lot of meats and animal fats and you don't eat hardly any carbohydrates, yeah, that their blood sugars are going down, but their cholesterol levels are going up, okay, because of all the animal fats. Now, lipids in the bloodstream attach themselves to proteins. So low-density lipoproteins and very low-density lipoproteins, those are the bad cholesterol. High-density lipoproteins are the good cholesterol. Those we tend to look at as being cardioprotective. They protect the heart. So you can remember the good and the bad this way. The low-density lipoproteins will lower you into the ground. The high-density lipoproteins will keep you healthy. Okay? So remember it that way. Now, what they want to see these days is that you have a total cholesterol of less than 200 milligrams per deciliter. You know, they keep lowering this. I remember when I was in nursing school, you wanted to see it below 240. And then they lowered it to 220, and now it's 200. And sometimes they're even treating people at 190 if they have other risk factors. LDLs and VLDLs are associated with cardiovascular disease. That's the problem, coronary artery disease. LDLs, if you have, you want them to be below 100 milligrams per deciliter. But if you have a smoker, smoking makes you at risk for cardiovascular disease. So if you have a smoker, they may treat them with medication earlier because they have multiple risk factors for coronary artery disease. Now, like we said, the HDLs are cardioprotective. They want them above 40 milligrams per deciliter with the male and 50 with the female, especially postmenopausal. Now, what's one of the only ways to get the good cholesterol, the HDLs, up? Exercise. They're affected very little by diet. Okay, so exercise. You can't go to your doctor and say, oh, I know my HDLs are low, but you know, I walk 4 miles every day. Well, you must be walking at a snail's pace because your HDLs don't lie. Okay? Triglycerides, they want those under 150 milligrams per deciliter. Now, one of the drugs that we use to treat high cholesterol is called statin drugs. They are some of the most widely prescribed drugs. Lipitor is a statin drug. Okay? Lipitor for a long time was like #1 in the most frequently prescribed medications in the United States because cardiologists think everybody should be on a statin drug, pretty much. And so what they're doing is they're having new guidelines. If you're a diabetic, you need to be on a statin drug. That's in the guidelines, even type 2 diabetics. If you have a history of heart disease, you should be on a statin drug. If your LDLs are over 190 and you have another risk factor, you're probably going to be put on a statin drug. And an increased risk of MI within 10 years. In other words, you have multiple risk factors. Maybe you're a smoker, maybe you're also obese, have a history in your family of heart disease, all those things that can go along with that. Now, with the drugs, how do they work? Well, let's look at the chart in the parish on the HDLs. I mean, on the drugs, the anti-lipemic drugs. Okay, statin drugs decrease cholesterol synthesis in the liver. In other words, statin drugs keep the liver from making as much cholesterol. So they work in the liver. They're going to be hard on the liver, statin drugs. Now, you can easily recognize the statin drugs because they end in statin. Atorvastatin is Lipitor. Very common. Pravastatin, rosuvastatin, simvastatin. Okay, those are all statin drugs. They don't have any real common side effects, but we're going to talk about what you have to watch for with those drugs in just a minute. Now, there'll be some people who can't take statin drugs because of the side effect that I'll talk about in a minute. Those people would probably take one of the other drugs that work in the intestines by absorbing cholesterol from the foods they eat. Okay, you can have bile acid sequestrants. Those bind cholesterol with the bile acids and it's excreted through the stool. You also can have cholesterol absorption inhibitors. Those keep cholesterol from being absorbed in the intestines. Now, both classifications of these drugs work in the intestines. So that's going to tell you that side effects will probably be where? In the intestines. Patients sometimes complain of gas, bloating, diarrhea, or constipation with these drugs. Okay? They work in the intestines, so the intestines may be affected, although they say that the side effects are not common with those drugs. Yeah, the drug absorbs the cholesterol, so it's not absorbed into the bloodstream. Okay. Niacin can also be something that can probably help with cholesterol, although I will tell you that is controversial right now. I saw an article last year that questioned whether or not niacin really did this. Now, you can't tell your patient, oh, you have a high cholesterol, just go take a whole bunch of niacin. What's wrong with that? Yeah, you could end up with a vitamin toxicity, a niacin toxicity, so we don't want to do that. Now, the reason why cardiovascular doctors like statin drugs so much, one of the reasons is because they stabilize the endothelial plates in those patients who have atherosclerosis. Okay, atherosclerosis, fatty deposits in the blood vessels, okay? What happens is the cholesterol is deposited onto the side of a blood vessel. Well, that makes it very uneven. And anytime you have an uneven surface in the blood vessel, then you tend to have like platelets and blood cells that tend to stick there, and they form blood clots. That blood clot can then become an MI, cause an MI, or cause a CVA. Okay? So they could have a stroke or a heart attack based on that. The statin drugs tend to smooth out those endothelial plates. And so you're not going to have those blood cells coagulating there and causing blood clots. So that's another reason why these drugs are used very frequently. So like I said, they tend to end in statin, atorvastatin, rosuvastatin, simvastatin. They work in the liver to decrease the synthesis of cholesterol. For that reason, they can be hepatotoxic. So they're going to monitor liver function. They're going to give the drug to the patient. They're going to tell the patient, come back in 3 months. In 3 months, we're going to check your liver enzymes. We'll probably check them every 3 months for the first year. And then after that, we'll check your liver enzymes annually. So they will continue to check to make sure the statin drugs are not damaging the liver. Now, they don't have real common side effects for the statin drugs. They're pretty easy to take, but there's a life-threatening side effect that you need to be aware of, and that is a condition called rhabdomyolysis. Rhabdomyolysis is when the body starts to break down muscle tissue, and when it breaks down muscle tissue, those clumps of muscle tissue start to be deposited into the organs. Many of them end up with some type of organ failure. I've only taken care of a couple of patients with rhabdomyolysis. I worked in ICU, and because it doesn't happen very often. But what we would see is that many of them would come in very, very ill. They'd start having organ failures. The ones I took care of, they died within 3 or 4 days. Okay? The first sign of rhabdomyolysis is muscle pain. So if you have a patient who's on a statin drug and starts complaining of muscle pain, they may take them off of it. In fact, some patients who have muscle pain with these drugs can't take them for that reason. They don't want it to progress to rhabdomyolysis. Some patients who take statin drugs complain that they tend to have Charlie horses, those muscle cramps. You know, that's okay. It's not that frequently, but it can happen. So, you want to tell your patient, report any muscle pain. Now, statin drugs are more therapeutic if you take them in the evening. When does your body make cholesterol? Yeah, at night while you sleep from the foods you ate during the daytime. So some of these actually say take in the evening. Others, it doesn't really matter. Okay, let's look in the parish right now at Joe. Joe's last blood work for cholesterol levels were total cholesterol 362 milligrams per deciliter, LDL's 154, and HDL's 32. So what do you think about this? Okay, is the total cholesterol high? Yeah, it should be below what? 200. LDLs, that's the bad cholesterol. LDL should be below 100. And the HDL should be above 40. Okay, so he doesn't have much good cholesterol there, not enough anyway. And so they're probably going to put him on atorvastatin. So let's look at that drug in the parish. Okay, contraindicated if the patient already has liver disease. Okay, renal failure, uncontrolled seizures, those are other contraindications. It interacts with digoxin, erythromycin, macrolide antibiotics, that would be like azithromycin. I actually know someone last year who went to urgent care because she had bronchitis or something she couldn't get rid of. And she said, I thought they'd give me azithromycin. That's what they usually give me. Why didn't they give me azithromycin? I said, because. Do you take cholesterol medication? She said, yeah. I said, well, there's interactions between those two. So that's why they didn't give you azithromycin. They gave you a different antibiotic. So you can have interactions there. Azole antifungal drugs, okay, patients who have funguses. They also interact with grapefruit. Do y'all know that guy on the radio, the food critic, Tom Fitzmaurice? Y'all don't know him? He has a show on WWL. I was listening to it one day on the way home. And he talks about different restaurants and places like that. It's like a 3 or 4 hour show. People call in with questions and comments and all. Anyway, he was saying one day, someone called in and said, have you been to such and such a restaurant and had the something grapefruit something? He said, oh, no, I haven't tried that. He said, I can't have grapefruit because I take cholesterol medication. And I thought, yes, somebody did a great job teaching him about that medication because he knows that. They also interact with oral contraceptives. Okay, side effects. No common side effects, but we do know that we have a very serious side effect called rhabdomyolysis. So you want that ongoing assessment for muscle pain. Now, statin drugs can increase the blood sugar. So this could be a problem, especially if the patients are diabetic. Monitor liver function and minimize the alcohol intake. And the reason why you're minimizing the alcohol intake is you're taking a drug that's already hard on the liver. So you don't want to double assault it with alcohol. Okay? Tell your patient to report muscle pain. Okay, diuretics. Diuretics are used to have the patient lose fluid. Okay. Diuretics, I guess the lay term for that is fluid pills. And so we're going to talk today about thiazide diuretics and carbonic anhydrase inhibitors. Okay. Thiazide diuretics work in the distal tubule of the kidney, and the carbonic anhydrase inhibitors work in the proximal tubule. Well, that's okay to know because where they work in the nephron depends on what the patient loses. Okay, so let's look at thiazide diuretics first. We know that we give them to induce diuresis. In other words, the patient's going to lose a lot of urine. They're going to end up with less circulating volume, and that is going to lower the blood pressure. Usually when the patient goes to a doctor for the first time with high blood pressure, the first drug they will put them on is a diuretic because they will want them to lose any extra fluid they have in the body. If you have less circulating volume, then the pressure will go down. Okay? They may tell them come back in about 3 months, and if the pressure is not down, your blood pressure is not down, then they'll put them on an antihypertensive. Now, the concern about diuretics is that the patient could potentially have a problem with fluid balance, maybe dehydration, acid-base imbalance, or electrolyte imbalances. So that's the thing we're concerned about. Now, thiazide diuretics, okay, those are derived from sulfonamides. And so sulfur drugs, you want to ask the patient, are you allergic to sulfur drugs? They work in the distal tubule of the kidney, and they inhibit sodium chloride water reabsorption. They are considered mild diuretics, so these are not some of the strongest ones out there. Now, I want you to know what the patient loses and what the patient retains. You lose water, sodium, chloride, potassium, magnesium, and bicarbonate. And you know what that is determined by is probably the size of the pore in the membrane in the kidney, and the size of the molecule of the substance. okay? So these are probably real small molecules. Calcium, uric acid, glucose, and lipids go up. Those are large molecules, okay? And so know what you retain and what you lose. So like we said, they treat mild hypertension, peripheral edema, but the person has to have normal kidney function. You know, you can't lose fluid if the kidneys aren't working well. So you have to have kidneys that work well. There are some thiazide-like diuretics that you can use with people who are beginning to have kidney problems. The most common thiazide diuretic is called hydrochlorothiazide. And you often hear it abbreviated HCTZ. You know, people don't want to say hydrochlorothiazide, I guess. Nursing considerations. You have a patient on the diuretic, you tell them to take it first thing in the morning. Okay? They're going to lose fluid. They're going to have to go to the bathroom pretty often. You don't want them doing that late at night, during the night. Okay, so take it in the morning. They work for about 6 or 8 hours or so. In the hospital, if we put them on this, we're going to check their urine output, check their blood pressure. Tell your patient to weigh themselves early every morning, same scale, same amount of clothes, same time. Okay? If they gain 2 pounds or more, they need to contact their healthcare provider. Someone who's taking a diuretic, gaining 2 pounds of fluid could make a significant difference in their blood pressure, their heart failure, something like that. So we want to know. You know, it's hard to gain 2 pounds in one day. Think about it. You would have to eat, each pound is about 3,500 calories. So you'd have to eat 7,000 calories on top of what you already eat each day to gain 2 pounds of fat. Okay? So, I mean, I don't think you eat 10,000 calories even on Thanksgiving Day. You do? Oh, but that has a lot of sodium in it, so you're going to be retaining fluid. Okay? Serum sodium, chloride, I like glazed too. Potassium, magnesium, calcium, uric acid, glucose, lipids, those all go up. Now, thiazide diuretics tend to make your urine more alkaline. And the problem with the urine being more alkaline instead of acidic is that it predisposes you to UTIs. Okay? Acidic urine keeps the bacteria and other organisms from growing in your urine. Teach your patient to eat foods high in potassium and magnesium because they're going to lose potassium and magnesium through the urine. So what might some of those foods be? Okay, banana, tomatoes, potatoes. Citrus fruits are high in potassium too. Magnesium, leafy green vegetables are magnesium. Carbonic anhydrase inhibitors. They block the enzyme carbonic anhydrase. Sodium, water, and hydrochloride, bicarbonate are excreted in the urine. Calcium, glucose, and uric acid will go up. Remember, those are large molecules. Now, these two are considered mild diuretics, but they also decrease the production of aqueous humor. So that can be very important in patients who have glaucoma because their problem is increased intraocular pressure. So if you have less aqueous humor, that can make the pressures go down. Acetazolamide is the most common carbonic anhydrase inhibitor. So you monitor the urine output, the sodium, the glucose, the uric acid, and one of the side effects could be that you develop crystalluria, okay? And with crystalluria, you could develop kidney stones. Okay, so any questions about the diuretics before we go on? Okay, let's talk about some anticoagulants. There are a number of anticoagulants on the market, and we're going to talk about several of them today. the first one we're going to talk about is a low molecular weight heparin. Enoxaparin is the drug that we're going to talk about here. Okay. Well, you know what? Before we do that, I'm sorry. Let's go back to the parish and look at hydrochlorothiazide in the parish. So Joe had a history of hypertension, diagnosed over 20 years ago. When he was first diagnosed with hypertension, they usually put them on a diuretic. So he was probably placed on hydrochlorothiazide. Okay, so contraindicated if the patient is allergic to sulfa drugs. That was on the first page of the parish. First page. Also contraindicated with anuria. In other words, they're not making any urine. They're not going to be able to get rid of the fluid that way. Electrolyte imbalances, dehydration. It's going to only make those worse, so it's contraindicated if they have that. Contraindicated means when you don't want them to take it. Now, we talked about how they work. Before you give this medication, you're going to check the blood pressure and you're going to check the patient's potassium level. You know, you wouldn't want to give it if the blood pressure is too low. You wouldn't want to give it if the potassium level is too low because it's going to go down further. The healthcare provider is going to have to correct the potassium level first, and then they'll start back on the diuretics. So after you give it, the blood pressure begins to decrease gradually over about 3 to 4 days, but you don't get your maximum effect for about 3 to 4 weeks. That's why they'll tell you come back in about a month and we'll recheck your blood pressure. Now, interacts with corticosteroids. It can cause hypokalemia, so you lose even more potassium. And also insulin. It will increase the incidence of hypoglycemia, the blood sugar going down too low. So side effects. Most common side effects, hyperglycemia. Diuretics tend to raise the blood sugar also. Hyperuricemia. Okay. That's going to be high uric acid in the blood. And hypokalemia, low serum potassium. Those can be side effects. So high blood sugar, high uric acid, and low potassium. Ask the patient, are you allergic to sulfa drugs? If they say it upsets their stomach, then give it with food. And we're always going to give it in the morning. So tell the patient to weigh daily, report 2-pound weight gain. You know, it may not affect you with your glazed pizza to gain 2 pounds of fluid. If you don't have anything else high in salt for the next couple of days, you'll lose that. But if the person already has high blood pressure that's not well controlled, or if they have heart failure, gaining that much fluid could really throw them into some problems, okay, that quickly. So monitor the glucose, electrolytes, BUN, uric acid, also for hypotension and dizziness. The INO, check for edema, change your position slowly because of that orthostatic hypotension. Also can cause photosensitivity, makes you very sensitive to light. You can get sunburned pretty easily. So you're going to protect your skin with sunscreen, stay out of the sun if you can, and teach the patient those foods high in potassium and magnesium. All right, now let's go on to anticoagulants. Enoxaparin is the drug we're going to talk about first here. Now, all of your anticoagulants will, in some way, stop the clotting process. You know how that's those steps to form a clot, like a 14-step process? Well, different anticoagulants will interfere with that clotting process at some step along the way. This particular drug, enoxaparin, inactivates factor XA and thrombin in the clotting cycle. Now, we have regular heparin, which you'll learn about next semester in Form 2. The low molecular weight heparin is considered a little safer. You have less bleeding with it. Any anticoagulant, the most common side effect and what you're going to assess for is bleeding. You're trying to keep them from forming a blood clot, but you don't want them to bleed to death. Okay? So think about it that way. Nursing considerations, bleeding. You're going to assess for bleeding from anywhere. In the urine, on the skin, maybe bleeding in the sputum, if they're coughing stuff up. bleeding in the stool, GI bleeding, just bleeding from anywhere. Now, the thing about enoxaparin that patients like is that you don't have to monitor special blood work with it. Some anticoagulants that we're going to talk about next semester, you have to monitor blood work continuously to make sure they're not to the point where they could hemorrhage to death. If you do give too much enoxaparin or any kind of heparin, the antidote is protamine sulfate. Protamine sulfate will go in and bind with those heparin complexes so that you end up with the heparin not being able to be used. Now, this is one drug that I know of. When you look it up in the drug guide, it tells you exactly how to give it. It tells you to give it deep sub-Q in the lower abdomen. Now, think about that. Even if you're a very thin person, you don't have an ounce of body fat on you, the place that you'll probably have some body fat is in your lower abdomen. Okay? So it tells you to pinch the skin, to inject it. We don't aspirate because you could cause bruising if you aspirate it. You inject the medication with the skin still pinched up. The reason for that is you don't want to let the skin go and the needle slips into the muscle. If it slips into the muscle, muscles are very vascular. You could have bleeding into the muscle. Don't want that to happen. Okay? So we're going to give it deep sub-Q in the lower abdomen. It tells you where to give it and how to give it. All right, so make sure you use those bleeding precautions. And that would be like if we had a male patient and we had to shave them, we wouldn't want to use a razor. We'd probably want to use an electric razor. If we hold pressure, we need to hold pressure longer when we give an injection or we draw blood, okay, because they could bleed that way. And then we're going to continually assess for that bleeding. So bleeding precautions. Now, there are a couple of, let's see. Let's look at enoxaparin in the parish. So James is a 96-year-old male who resides in a local nursing home due to dementia. James spends most of his days sitting in a chair in the common area of the nursing home. The nursing assistant reports that when bathing James, he screams with pain when she touches his right calf. So what are we concerned with there? Yeah, possible blood clot, okay? A deep vein thrombosis is a clot in the calf muscle, circulation. It's not in the thigh or the ankle or anywhere like that. It's in the calf. His physician's call, he's transported to the hospital for diagnosis and diagnosed with a deep vein thrombosis, prescribed enoxaparin for a 2-week period. Okay, contraindicated with active bleeding. And that would be bleeding from anywhere. That's why we assess for bleeding. Thrombocytopenia, low platelet count, ITP. Okay, those are all blood dyscrasias. In other words, there's something wrong with their clotting, and you add an anticoagulant to it, they're going to really bleed. Okay, so that's why it's contraindicated with those situations. Okay, before you give it, assess for bleeding. After you give it, you're going to continually assess for bleeding. Now, if the patient has a low platelet count, below 100,000, that's really low, hold it because you don't want to give it to them. They're going to probably have some severe internal bleeding. It interacts with. You don't want to give it with any other medication that also increases the bleeding time. Okay? That would be aspirin, your NSAIDs like ibuprofen or naproxen, Aleve, Motrin, Advil, all of those. They prolong bleeding time. They're antiplatelet aggregators. They make the platelets less sticky so they can't clump together to form a clot. There are also some herbs that you're going to hear me talk about over and over again with anticoagulants. These herbs prolong bleeding time, and I call them F and the 3 Gs. F is feverfew. The 3 Gs are garlic, ginkgo, and ginger. All 3 of those prolong bleeding time. Okay? Either one. Either one. Yeah. They just increase the bleeding risk. And that's fine. I mean, you're fine to use those in cooking and things like that, but not if you're also taking an anticoagulant. That's the risk, combining those. All right, side effect. Life-threatening can be hemorrhage. So we're always going to do that ongoing assessment for bleeding. We talked about how you give it, rotate your sites, and the antidote's protamine sulfate. Okay, this next one here is dabigatran etexylate mesylate. Y'all say that fast, huh? Also known as Pradaxa. And with this medication, this one is given to prevent strokes and MIs in patients who have atrial fib. So this one is a tablet that they take at home, not used if they have valvular disease in the heart, so the valves need to be working well. And it works by being a direct thrombin inhibitor. Okay? So for your nursing considerations with this one, bleeding, bruising, dizziness, weakness, all that could indicate some form of bleeding internally. So we're always going to be assessing for that. Look at the over-counter medications are they taking. Are they combining some of those meds that we talked about, that prolonged bleeding time, with this one? They shouldn't. They shouldn't take those. Look for gastric ulcers. Okay? We're concerned about gastric ulcers because gastric ulcers could start bleeding. Okay? So the symptoms of gastric ulcers are indigestion, stomach pain, burning pain, stomach upset, that type of thing. Look for unexpected swelling or pain or joint pain. It could indicate they're bleeding into the joint. Now, one thing that patients like about this one is that you don't have to monitor any lab work. Okay? But a not so good thing about this one is there's no antidote. So if you have an anticoagulant that doesn't have an antidote, what are you going to have to tell the patient to do if they start bleeding? Basically, go to the emergency room because they're probably going to need a transfusion of blood or plasma. They're going to need a transfusion of something with those clotting factors in it. Okay? Pregnancy category C, so take with or without food. So this one can be taken either with food or without food, whatever the patient chooses to do. Now, another one that is on the market that we hear a lot about is rivaroxaban. Rivaroxaban is Xarelto. Y'all heard those commercials? Yeah. We use this one for non-valvular atrial fibrillation. Also for deep vein thrombosis and pulmonary emboli, or preventing the deep vein thrombosis with knee or hip replacement surgery. Now, this one works by inhibiting factor XA in the clotting cycle. So for your nursing considerations, again, you're concerned about bleeding anywhere in the body. Dizziness, weakness, headaches, that could indicate bleeding in the brain. Over-the-counter medications, make sure they're not taking any other medications that prolong bleeding time, including those herbs we talked about. You want to look for any pain, swelling, or new drainage from wounds. That could indicate bleeding. Now, this one is taken in the evening. You can tell the patient to take it with their evening meal. If they say, I don't eat in the evening, then they could take it on an empty stomach. It might upset them, but they could. I'll tell you that I had a friend who I took to the hospital one day to have a procedure done. And when she got out of the hospital, they switched her anticoagulant from whatever she was taking to rivaroxaban. So the doctor came in to talk to her. The nurse came in to talk to her. Nobody told her, take it in the evening with your evening meal. And I knew that, and I thought, why are they not telling her that? I thought, well, if nobody tells her, by the time I take her home, I'll go ahead and tell her that. So sure enough, we go to the pharmacy to get filled. The pharmacist comes out and says, did they tell you how to take this? And she said, no, nobody said anything about it. And the pharmacist says, well, you need to take this in the evening with your evening meal. I thought, great. Somebody's telling her, okay? So make sure you tell your patient that, with or without food. but in the evening. Now, another one we're hearing a lot about, well, let's look at rivaroxaban in the parish. So rivaroxaban is contraindicated with bleeding, liver or kidney disease. Okay. And we talked about why we use it. Assessing for bleeding is very important. It interacts with clopidogrel, which is Plavix. That's another anticoagulant. And those herbs that we talked about, including St. John's wort. And you're also going to look at over-the-counter meds to make sure none of them prolong bleeding time, like your aspirin, your ibuprofen, those. Now, what now? 7. Yeah. Side effects you want to be concerned about: hemorrhage anywhere, internal, external. And it could elevate the GGT, one of the enzymes in the blood. So that's pretty common to see that with this drug. Now, ongoing assessment for bleeding is very important. Monitor the vital signs. If you have a patient that you start to see some neurological impairment, okay, maybe they can't speak, they can't move as well, they may have trouble following commands. What do you think about bleeding in the brain? Okay, you know, when you have a stroke, a CVA, it could be one of two things. It could be either be a blood clot in the brain or it could be bleeding in the brain. Okay, so neurological assessment is important there too. Monitor those liver function tests, the kidney function, hematocrit and hemoglobin. Hematocrit and hemoglobin is your blood count. If the blood count's going down, that would indicate internal bleeding. Check with the healthcare provider before they use anything like aspirin or NSAIDs or herbal products. And we talked about taking it with the evening meal. Now, another drug that you may hear advertised is apixaban, which is Eliquis. So this is a little bit newer one. It also inhibits factor XA. Rivaroxaban, I was told about 6 months or so ago, somebody told me that rivaroxaban now inhibits more than just factor XA. It's actually about 6 different factors that it interferes with. And so that's why that one now tends to be prescribed for more serious, conditions. This one may prevent like a blood clot with someone who has atrial fib or something like that. So this is where you may see this one prescribed. Side effect, well, that increased risk of bleeding. That's a potential side effect. Nursing considerations. Again, you're going to assess for bleeding, ongoing. The problem with some of these drugs is there's no antidote for them. This one has a little bit longer half-life, 12 hours. So you probably only take this one once a day. No aspirin or NSAIDs. I think it was last year they came up with an antidote for rivaroxaban. So that one does have an antidote now. But some of the others, if they don't have them yet, then they'll have to go to the emergency room if they start bleeding to get some blood product that has clotting factors in it. Okay, let's go through some questions to finish up. The nurse is aware that the first-line drug for treating a patient's blood pressure is what? A diuretic. Okay, that's the first thing that they will use. So nifedipine is ordered for a patient with hypertension. In the care plan, the nurse includes the need to monitor for which side effects? Yeah, calcium channel blocker. It'll drop the blood pressure pretty quickly, and the body's compensatory response is reflex tachycardia, raising the pulse rate. A patient is taking a statin drug. Which adverse reaction should the nurse look for? Okay, rhabdomyolysis, and what's the first symptom of that probably going to be? Muscle pain, right. So the nurse is working with a patient taking simvastatin. So which patient's statement may indicate a need for further teaching with this drug? And further teaching means they say something that's wrong and you need to correct it. Yeah, D, I will take my pill with grapefruit juice. Okay. So a patient is taking hydrochlorothiazide for heart failure. So which of the following lab levels should the nurse monitor closely? Potassium level, because they lose potassium. So what patient education should be included for a patient receiving enoxaparin? Okay, you're going to look for bleeding anywhere, including unexplained bleeding from the gums or in the urine. A says to teach the family to give it IM at home. Do we give it IM? No, we give it sub-Q. Tell them to take any over-the-counter products. No, we don't want something that prolongs bleeding time. And teach the patient to monitor for the development of electrolyte imbalances. We don't have electrolyte imbalances with enoxaparin, an anticoagulant. Okay, do y'all have any questions? All right, y'all have a good day.